I would like to thank the organizers for giving me this opportunity to speak. So this is a very unique phase 3 trial, which is trying to influence and incorporate a molecular imaging. So this was done by Jeremy Calais, who from the UCLA Center. So they work in the Department of Theranostic and Molecular Imaging. So it's a nuclear medicine department which had initiated this trial, and this was collaborated by the NCI. And this was done at a time when there was COVID time, so it's been completed in a record 2 years. So which is again really credit to the investigators who've done this trial. So giving you a small background about this trial. So this particular trial, we know that biochemical recurrence takes place in 20 to 80% of patients within 10 years, after radical prostatectomy, based on the different NCCN risk groups. The concept of giving radiotherapy is now shifting from adjuvant radiotherapy to early salvage radiotherapy treatment, and the whole gist is to try and detect them as early as possible. So you do a PSA, and as soon as the astrophoenix definition is met, which is more than 0.1 nanogram, we would call this as biochemical relapse. And the idea is that earlier you treat, the better are the outcomes. But the overall salvage radiotherapy, we know that can cure almost 50 to 60% of these patients. Now, the standard of care imaging for these particular patients who have got very, very early sort of recurrences, the problem is it's too insensitive to detect the real site of recurrence at this particular PSA levels. So hence the thing is there is this new radioligand 68 gallium PSMA 11 molecule, which is highly specific. It is reproducible, produced from a cyclotron machine, and it is superior at detecting early disease. The same group have done some 270 odd patients, and they've said that if the PSA is less than 0.5, there's almost a 50% detection rate, whereas 95% of patients would have detectable disease when the PSA is more than 2. So the question, the thing is really this trial is trying to answer is, could we incorporate this PSMA CT PET scan and help the radiation oncologists to try and see if we can influence and improve the outcome of successful salvage radiotherapy treatment. So this is the trial schema. The inclusion criteria: you need to have patients who are histologically confirmed prostate cancer, those who have had a biochemical relapse, PSA more than 0.1. They should be willing for radical radiotherapy treatment. The treating radiation oncologists should be able to randomize, and those where the thing is they are randomized in the arm of PSMA CT PET scan, the radiation oncologist should use that information from that and influence the plan if they must. The exclusion criteria would be any patients having extrapelvic metastasis, as it was believed that these are metastatic cancers, and they may not, many clinicians would not treat them with radical intent. They shouldn't have gone to a medical oncologist. So the thing is, any patient going to a medical oncologist where ADT has been started, or novel hormonal agent has been started, or any systemic therapy is started, they would be excluded from this particular trial. And of course, there shouldn't be any contraindication for radiotherapy like inflammatory bowel disease or any other condition. So these would be the exclusion criteria. So now the hypothesis is that, if the thing is, we know that the hypothesis is at the bottom 60% SRT success rate. So this was known from their retrospective data. So the hypothesis is, could this be improved to 80%? Or in other words, could you reduce the failure from 40% to 20%? So they came out with this randomization of 1:1.13. Why 1.13? Because the thing is, they said that the 13% patients having a PSMA CT PET scan would have extrapelvic metastatic disease, and these patients may not have salvage radiotherapy treatment. And the thing is, it's best to exclude, as their prognosis will be different. So hence they had to have more sort of power on the interventional arm, and hence the randomization was 1:1.13. So in the conventional arm, so these patients would be, they would have any standard of care imaging, be it CT scan, bone scan, MRI, whereas in the interventional arm, the PSMA CT PET scan would be done, and the thing is the radiation oncologist would have access, and they had the opportunity to change their management plan based on that. So now what they have done is they have asked the radiation oncology to fill case report forms as what they would do prior to randomization, what would be the radiotherapy plan. And then the thing is, at the end of treatment, they would actually have to submit another case report form of actually what has been delivered. And this was all recorded. In this particular trial, the radiation was left to the clinician's discretion. They could treat the prostate bed only. They could treat the prostate bed with pelvic nodes, and later on they even added they may or may not have ADT. after the results of the SPORT trial came in, so they added, plus or minus 6 months of ADT as well into this, giving the clinician some freedom. So the primary endpoint was the success rate of salvage radiotherapy treatment, defined as the biochemical progression-free survival, any PSA more than 0.2, and this was calculated after initiation of SRT until the date of first progression or death. And the secondary endpoints were 5-year the biochemical progression-free survival from the date of randomization, metastasis-free survival, initiation of any additional salvage radiotherapy treatment, and the main crux of this trial was to look at the change in the treatment intent. Whether were there any major, minor changes, I'll come to this in a minute. Was there any treatment escalation, de-escalation? And that is the focus of this particular paper, as this is an initial abstract. We don't have the final results yet. So this is a schema. They had 193 patients enrolled between 6th of September to 17th of August. So completed record within 2 years. 90 control subjects and 103 intervention subjects. There were 13 dropouts, 8. In fact, the thing is, they got randomized to the control arm with no PSMA, but the thing is, they used their influence and they got PSMA done at other centers. And the thing is, 8 patients sort of thing is, they were excluded. And there were 5 who withdrew consent. So they may have gone to the medical oncologist and some systemic treatment or something was started. So they also withdrew the consent and they were out. So eventually they were left with 77 patients who proceeded with standard imaging, and there were 103 patients, out of which there was 1 dropout. So this was a patient who had severe complications of COVID, and he could not even have a PSMA CT PET scan, but he was randomized to the intervention arm. So these are the baseline characteristics. So the median time from surgery to enrollment, 20 months. So you can see that there's an outlier that even after 20 years, 245 months, there is a patient who's had a relapse, and the thing is, these patients were randomized. Whereas in the interventional arm, 28.3 months. So again, the range being 1.2 to 210 months. So again, almost 16, 17 years, this patient has had a relapse. The median PSA, 0.3 nanograms and 0.23 nanograms in the interventional arm. And you can see the range that, even patients with 29.9, almost 30 nanograms per ml, even these were, included in the trial. So in the interventional arm, there were 37%, so 38 patients who had a positive PSMA PET scan. 12% were true M1, where the metastasis was found outside the pelvis. 20% had pelvic lymph node metastasis, and 13% had prostate-only metastasis. So here, the pre-randomization RT plan, which I mentioned, prior to randomization, the oncologist was supposed to mention what they're going to do. They were available for all 100%. And after actually, eventually what treatment was given, so that plan was available in almost 86% and 99% in the interventional arm. So these were the data collected, the radiation field, the doses, whether ADT was used or not used. So all these were incorporated, and even the changes were recorded. So I spoke about the secondary endpoint analysis, and the secondary endpoint had these major changes and minor changes. So what are these major and minor changes? So any change of ADT duration for more than 3 months, so that would classify as a major change. Change in the RT volume, target volume delineation beyond the standard field, adding a simultaneous integrated boost beyond the standard radiotherapy field, and any initiation of systemic therapy, whether they would be novel ADT or chemo, they would be classified as a major change. Whereas minor changes would be using an SIB, a simultaneous integrated boost within the standard radiotherapy field. And these are the results. So basically, it showed that in the control arm versus the interventional arm, there was a 7% minor changes were incorporated by the radiation oncologist. Major changes were 22% in the control arm, whereas 44% in the interventional arm, with escalation seen in 30%, de-escalation in 12%. These are in the interventional arm, as opposed to 9 and 8% in the control arm. And there were mixed changes. So here to summarize, the change in management which were PSMA related were almost 32%. There were lots of other changes which were made in the management plan, but these were all patient, physician choice or non-PSMA related. So we don't have the detailed breakup of these. So this is a schema which shows that, in the control arm, 77 patients who proceeded with the treatment, 60 had proceeded without any change, whereas 17, there were some major changes. Whereas in the interventional arm, there were 53 major and minor changes, 49 proceeded without any change, And there were 36 who had escalation, 13 de-escalation, and 4 were alternative therapy decision. So my conclusion, this is the first prospective phase 3 trial which has tried to incorporate a molecular imaging modality to influence the SRT therapy. The PSMA PET findings provided information to the radiation oncologists, which initiated a major change to the SRT in 32% of patients, almost a third. The major changes between the pre-randomization RT plan and the definitive RT plan was 44% in the PSMA versus 22% in the controls, almost double. And these trial subjects, of course, will be monitored and, to see really the impact on the 5-year biochemical recurrence-free survival, and probably we'll have these results in ASCO 2025. Thank you.